today, everyone, we are very fortunate to have our guest lecturer, Dr. Nicos Labropoulos. He doesn't really need any introduction. He's the world's foremost non-invasive vascular imager on the planet. Nicos has given this talk quite a few times, but we were just talking before we jumped on that the more I see vein patients, the more I realize that the variant is the norm. So Nicos is going to give us some talk about clinically relevant venous variants. I think this is very important because it really does affect your management. And you not only need to know how to recognize this, but you have to teach your techs as well. So Nicos, thank you very much, and go ahead.
Thank you, Peter. It's a pleasure. Good morning, everyone. Let's make it truly clinical relevant. And here is my email. If any of you has any further questions, any help with anything, I'll be very happy to. Now, I like to start with a paper we did with one of my medical students at the time, which is now my colleague, Dr. Labropoulos. And what we did, we looked, the saphenous trunks, and we saw various things. One, that varicoses on the trunks themselves, like see the great or the small, are actually rare. I found only 5% of people. So we talk about varicose veins, we talk about the tributaries of the veins, not the trunks themselves. However, when you notice them in the trunk, it's very important because you need different maneuvers to do your ablation techniques. When you go to the small saphenous, this is the most complicated vein based in the lower extremity due to its embryological development. And as you see, the saphenous vein terminates in the popliteal in 2/3 or 3/4 of the people, maybe. And as you see here, there is an extension with, 4 different types with at least 9 variations. Now, when we look at the saphenous systems, what we look for reflux, if there is any obstruction, the diameter of veins is relevant to the treatment, the distance with the skin. Then other common things like hypoplasia, aplasia of duplication. The duplication is kind of less than 2% in the saphenous veins, but hypoplasia and aplasia is very common, reaching up to 20%. Then we look at the accessory veins, the tributaries, the perforators, and the deep veins. Now, when we examine the patient, it's very important to put him on the standing position, and we inspect the leg from all different angles. In this way, we see the distribution of the varicosities, or the signs, or if there's any symptom as well that the patient can tell us. Now, in this, I work, for a bit with Dr. Jean-François Hull, who's a vascular surgeon from the University of Descartes in Paris. And here is a CAT scan in a cadaver using the 3D volume rendering technique. Imagine the veins have been filled with latex to show very nicely the CAT scan. You see very nicely here the anatomy of the great saphenous from the marginal arch to the groin and the small saphenous vein, right? From the popliteal fossa to the lateral malleolus. But you see here the main interconnection between the two saphenous systems. And these are important to understand because they determine when we have reflux from the great to the small, which is more common, from the small to the great, which is the least common, and combinations of the two, or having reflux independently in each vein. Another area which is very interesting, particularly after previous surgery, is a violation basically of the groin, creates what we call this lymphovenous networks that we published Dr. Jean-François Hull 6 years ago. And you see the lymph nodes in here, like you on the ultrasound, have veins, and often they dilate and become incompetent and have reflux. Obviously, you cannot remove the lymph nodes of the patients, and these people will choose to treat with ultrasound-guided form sclerotherapy. But it's nice to recognize, see one vein here, and you see the reflux inside these veins. And if you look at our drawing from our patient, this patient has a previous ligation, the saphenous vein here is normal, but I see the lymph nodes and veins coming from the anterior accessory, which is actually the most common vein to give the lymphovenous networks. You see very nice in this cadaveric preparation in here. Now, anatomically, what's interesting, often we see 2 veins in the thigh, and people call this duplication. By anatomic definition, only if this vein is inside the canal is called saphenous and true duplication. Here what we see, you see the saphenous vein and an accessory vein. The accessory is dilated as reflux and the saphenous vein is normal. That's why this you cannot tell with your physical exam. You need ultrasound for proper documentation with the correct, vein mapping and perform your treatment. Here you see what we call a true duplication because both saphenous veins are inside the saphenous canal. Right? This is the deep fascia here, and this is the superficial fascia. This is very uncommon. It's found in less than 2% of the people, but it's good to know because sometimes one of the veins may have problem or both. And here you see another variation where basically the great saphenous vein comes outside the canal. If it comes outside the canal, it cannot be longer called saphenous vein. And then you see here the distance from the skin, and here, which is 1.2 millimeters, centimeters, and here it's just basically less than 2 millimeters. This vein here, although it's the same one, is not the saphenous anymore. The saphenous is the vein inside the canal, and the patient has what we call segmental aplasia, which is one of the most common variations in the human lower extremity. And here is an example of hypoplastic saphenous vein measuring basically half of a millimeter inside the canal. That's a true hypoplasia at the lower thigh. It is an example of aplasia because there is no vein in the canal. And the vein has been, the area has been drained by this dilated accessory, which in this patient happens to have a reflux as well. See, it measures 7 millimeters. And here is a drawing, a vein map from one of our patients, showing a patient with a hypoplasia and aplasia. You see the saphenous vein at the junction is normal, farther down is good, and then it's tapering down to be hypoplastic. You see the two accessory veins, and here is true aplasia in the knee area, which is fairly common. We discussed this. Take this. What I like to remind you here, the popliteal vein is down at the bottom. This is the saphenous vein joining the popliteal. That's the saphenopopliteal junction that is present in 3/4 of the people. So 1 every 4 people does not have a saphenopopliteal junction. Here's another anomaly where the medial gastrocnemial vein connects to the great saphenous, the small saphenous, and both come out together popliteal. And also, you see the thigh extension of the small saphenous vein. Here's another example where you see the small saphenous vein having reflux, the thigh extension having reflux, the saphenopopliteal junction, and the gastrocnemial vein joining. So it's nice to know the anatomy because if you don't know what you're doing, obviously you may do the wrong thing. Going to the deep veins now in this area, the most common anomaly is the duplication of the femoral and the popliteal veins. As you see here, this is a patient with 2 femoral veins, it's the artery in the middle, and as you see now, both veins have reflux. What's very interesting, you can see very clearly, the top vein has post-thrombotic reflux with filling defense effect and synechia. This is very important because if you know the patient has a previous DVT, you can prophylax the patient when you do a procedure because the biggest risk factor for getting a VT event is a previous VT event, basically. Also, it's very important to know because if your patient has, persistent signs and symptoms, you can tell, okay, I treat your superficial veins, you may get better, but the persistent problem with the deep system, right, it won't allow the patient to come back normal. So you have to tell this patient to, manage the patient's expectations. And of course, in a patient like that, he may or she may continue to wear elastic compression stockings after the superficial vein treatment. And here you see a duplicated popliteal vein, it's fairly common as well. You see the artery in the middle, and you see the 2 veins here. You see on the top the tibial nerve, this is the gastrocnemius muscle, the tibial nerve, the 2 popliteal veins. Now it's important to know about duplication because sometimes only one of the 2 veins is thrombosed, and it can be easily missed, so you can have a false negative finding. Having a false negative finding for DVT in a vein from the popliteal level of height is very important because the chance for pulmonary embolism is high. I like to bring it out to a paper we did. One of my medical students, actually was a college student at the time, and now he's in a medical school finishing. He wants to be a vascular surgeon. And you look at the basic test, the symmetry between the lower limb veins. If you look now, this is the superficial system, the great saphenous and the small for aplasia, hypoplasia, duplication, or an aneurysm. You see these frequencies, right, are higher for hypoplasia, but obviously there is complete asymmetry on each side. And this is for the healthy subjects with no venous disease, patients with class 2 to 3 disease, and people with skin damage as well. So it doesn't matter whether you are normal or patient, you're bound to be asymmetrical. And this goes true for the deep veins, for example, looking at the femoral vein for aplasia, hypoplasia, duplication, triplication, or an aneurysm, and the same is true for the popliteal vein. And also, when we look at the calf veins, it was even more common because the variability in the calf veins is higher. And here we look only for overt changes, and we do not look all the veins. And yet, the chance for being symmetrical is 0%. And I said that we are, born to be asymmetrical. Well, despite the perceived resemblance of symmetry between the right and left lower limbs, these are significant overt differences. There are significant overt differences. A complete lack of symmetry is consistently seen in chronic venous disease patients and healthy subjects. Asymmetry in the lower limbs appears to be the norm, and actually is. This is true despite examination of only overt changes and exclusion of multiple veins for the comparison. This apparent symmetry breaking is an important physical concept described not only in medicine, but also in other fields of scientific inquiry. Defined as a process of random events, this natural preference of entropy over order can be attributed to developmental differences and highlights the impossibility of maintaining perfect symmetry. So when you examine a patient, looking at the left and right limb, you're going to find basically often different things. And you have to be aware of this so you can manage your patients better. So let's go to some veins that are not as common, such as the non-saphenous veins. And these patients were examined in a starting position like I told you earlier. And basically, we found 84 limbs in 70 patients for a prevalence of 10%. Most of them were female, having at least 2 pregnancies. This is very important because these varicose veins often connect with pelvic veins. It's very important for you from your physical exam. So you may ask the patient the right questions for the abdomen and the pelvis, and the patient may have to be treated for pelvic vein disease. If you look, the study by Bernardini, he confirmed our findings, finding no saphenous reflux in 11%. And also, if you look at our prospective study with Dr. Puren, right, for recurrent varicose veins, the prevalence increases. Well, it does increase because many people don't know about them and they leave them not treating them. So when the patients come back from this group, obviously the prevalence is higher. If you look at the distribution, where these veins come from posterolateral thigh, valvar area, gluteal, sciatic, these 3 typical are veins from the pelvis. And then again from popliteal fossa and any area. And here is an example of the posterolateral perforator. This is the longest perforator of the human body and connects usually the deep femoral vein or the femoral vein or muscular vessel of the thigh with the lateral venous plexus as you see here. Right? And this has nothing to do with the saphenous veins. This is the fascia lata here, the vein penetrating down, a lot of reflex is big, and this is the perforator, the tributary. Here is the vein of the popliteal fossa, often confused with the small saphenous vein, but this vein comes a bit more superior to the sacropopliteal junction and has a lateral course. See this beautiful venogram from Mr. John Hobbs, who taught me actually this vein a long time ago, right? And you see here a patient of mine, which is similar to this, showing the varicosities going to the popliteal fossa, basically. And this is from the same patient, the huge reflux. Now, what is interesting here, this non-saphenous vein, and most of them, are extremely varicose, like you see, and thermal ablation, right, it cannot be performed in such patients. So typically do phlebectomies and injections. And here's one of our patients with such a vein, with abnormal course, because usually this vein is a little bit more lateral, but here's the popliteal increase, and that's a vein of the popliteal fossa. And you can see nicely in the zoom view now here, very nicely, the trajectory of the vein. See the varicose now on the top coming from the vein. This one penetrates the deep fascia. There's a lot of reflux. You see, they're so varicose, it's impossible to do basically any ablation techniques. And here you have to be careful sometimes because you have to see the nerves. This is the common peroneal nerve, and this is the tibial nerve. So if you are to ligate the vein, if you see this on the ultrasound, it stays clear because you don't want to damage the peroneal or the tibial nerve. And here, with this occasion, we ligated the vein. Right? The vein was ligated here at the popliteal fossa, and here taking out the tributary with phlebectomies. You can see now the vein here, and in the zoom view, even if you stretch it, look how varicose the vein. Imagine when it's at the relaxing position, how varicose is it. So there's no way to negotiate any catheter in here. There are some other veins in the lower posterior thigh, like you see in this area here. Right? These are typical perforators, and this is a knee perforator here. And then I have, of course, the venous sciatic nerve we published in 2009. Actually, it's very interesting. This paper, this patient here is a 34 years old female, is a patient of Dr. Papas. I remember even her name, but I won't say it, obviously. And this varicosity here, you may think is a small saphenous or a bit of the grade. But when you do the ultrasound exam, right here, this veins emerge from the sciatic nerve, right? So, and if a patient is female and has pregnancies, it's very likely the sciatic nerves, they go all the veins, they go all the way to the inferior gluteal vein, and there's pelvic reflux as well. And here you see the variations between the sciatic nerve veins, which is basically they connect with perinerve veins, right? Then veins inside the nerve, they don't have valves. So when the veins around they become incompetent, then blood from the nerve comes outside the veins, and then the veins in the sciatic nerve enlarge. Or if it's coming from the pelvis, then you have huge varicose in the nerve drain from the pelvis to the nerve. And here some valvular veins are actually far more common, and they don't have any particular topography, but they come in typically medial to the saphenofemoral junction from the pelvis, as you see here, right? There's a lot of varicosities, and you see all these big tributaries from the pelvis. You may think that are from the saphenous, but if you continue, right, they go up all to the labial area. And here what we call is the gluteal vein. You see the vein here pierces the gluteal fascia. You see also in the ultrasound piercing the fascia here, right? And you see the CAT scan, the perforating veins in the gluteal area where they join the internal iliac tributaries with this system that goes in the posterior or posterolateral part of the leg. Such people have symptoms like the other, they're not very different. The majority present with class 1 to 3 disease, but 10% they may present with skin damage. And in our study, 80% of these limbs were symptomatic, which means 1/5 of our patients with this kind of veins, they treat it for cosmetic reasons. And here we found that the duration of disease, like with the saphenous vein, is important because the longer the disease, the more likely is to be symptomatic. So to remember for the non-saphenous, the prevalence is around 10%. So one of every 10 patients has these veins, but it's 20% of people with cardiac varicose veins. It's often found in females who have at least 10 pregnancies, and skin damage is present in 1 in 10 of these patients. Now, what to remember also, no saphenous vein reflux is frequently found in patients with CVD. It's very important to identify the patterns and extent of reflux in these veins in order to plan the management of patients. Treatment of these veins rarely involves thermal ablation because these veins are very tortuous. Microphlebectomies and vasculotherapy are used in the lower extremities for these veins. In patients that have pelvic vein reflux, selective immunographic catheterization with foam sclerotherapy for the pelvic fleshes and coembolization of the various veins are used. But don't forget, when you identify such veins, it is often common that these patients may have also pelvic vein reflux. Now, if you look now at the pelvis, look at the inferior vena cava first. right? This is the drawing of the inferior vena cava. This is, you see here nicely on the ultrasound, the spine here, the aorta and the vena cava here on the cross-sectional view, and the multiple tributaries such as lumbar veins, ascending lumbar veins, gonadal veins, the renal veins, suprarenal veins, the inferior phrenic and the hepatic veins, as you see here, are the most common tributaries of the inferior vena cava. Now, the vena cava can have also different anomalies. The way it's being formed in the embryological age, you can have, aplasia in the hepatic segment, infrahepatic aplasia, infrarenal aplasia, and you have also hypoplasia of a duplicated IVC. And other anomalies we're going to see are maybe have a left-sided cava, a mega cava, or a duplicated cava. And the IVC aplasia and hypoplasia often is congenital, maybe have thrombosis in the uterus, and probably even the more common is the use of catheters in the neonatal age, where the veins are occluded permanently and become very thin, and then collaterals take over. Now, this is a duplicate IVC in a male patient, 51 years old, presented with flank pain. And see if the video, sorry. You see the video here nicely, the aorta, you see the two veins on each side. Let's see the other video as well here on the coronal view. And you can see nicely as go down the aorta and the IVC on each side, right? There are two IVCs. And here's an example why this could be important. This is one of our patients when I was actually back in Loyola in Chicago, and the patient had duplicated IVC. You can tell this is an old because it's titanium Griffin filter, right, from a long time ago. And what happened is the patient got a filter because, to prevent a PE from a DVT because it could not be anticoagulated. But the patient did get a PE because the filter was placed in one vein, right, and the other vein was free. So you see the clot here on the CAT scan could go to the lung. When it was found out, basically the proper venogram, then another filter was placed. And here you see a left side IVC in a male with 39 years old, has a femoral fracture. You see the IVC is on the left side here, right? That's it. And then it splits the two iliac veins. You see the other side now here with a long view. That's the IVC, which is left to the aorta. So it's the left side of the IVC. And here you see a mega cava. It's a female, 64 years old, that has a cava measures 4.4 centimeters. That's pretty big vena cava. And you can see here on the CAT scan, the cava dwarfs the aorta. That's the aorta here. And you see on the cross-sectional view and also in the long view, that's huge vein, that's a mega cava. So obviously it is important to see this because when you try to treat obstruction further down with putting stents, or if you want to put a filter, this is a patient that you have to take either different measures. And it's a female patient, 18 years old, who presents with a DVT from the calf to common iliac vein. It's hypoplasia. It's the cava measures only 35 millimeters. And you see this large collaterals on the venography. And you can see here on the CAT scan, the hepatic level of the vein being small. This at the mid-level, the vein is tiny. And the distal IVC is so small here. And you see the acute thrombus on the left external iliac vein of the common femoral. Right? Typically, these people present with a higher rate of VT events at the young age, under the age of 30, and develop later bad post-thrombotic syndrome because, of course, they have compromised outflow and also iliofemoral DVT. He is a male patient, 17 years old, with right external iliac and common femoral vein DVT, had IVC and common iliac vein hypoplasia. That's very rare because the patient was born without an IVC and without iliac veins. And you see here on the ultrasound nicely, you see the aorta. This is the IMA, it's typically at 1 o'clock position, and there is no IVC next to it. And you see on black and white, the IMA, right? No IVC. And you see here the mid aorta higher up in here, just below the renal, there is no IVC. And you see the two iliac arteries, there are no iliac veins. And you see the acute thrombus on the right common femoral vein. The vein is dilated, right? It has echolucid material. So this is on the CAT scan, you see here again the aplasia, right, of the infrarenal IVC, and both common iliac veins. You see the arteries here, but there is no veins next to the arteries. You see all some large collaterals around. So it's a female patient, and this is a very nice example for other reasons. Present with swelling and venous claudication for 3 years after varicose vein treatment. Here is her history. Here is her physical exam. And what you see on the ultrasound here, this is the aorta. There is no vena cava. Look, the right gonadal vein. That's enormous. And we call this pelvic vein collateral. This patient mistakenly can contribute for pelvic varices as a pelvic vein reflux. But this patient has large collaterals taking the blood to the heart because there's aplasia of the vena cava. And here you see the right ovarian vein with flow towards the heart, and the left ovarian vein would flow towards the heart. So these are very dilated veins, right? It was 11 and 14 millimeters. That's huge, but there is no reflux. So you have to be careful while we're treating sometimes, okay? So this is collaterals for a patient having aplasia of the vena cava. And here you see on the video, on the ultrasound, on the video, how fast is the flow of these large collaterals, which is different from the really slow flow we see on the varicose veins in people having pelvic vein reflux. And here you see the CAT scan. That if you see the CAT scan, all you say, oh, these are varicose veins, basically, right? But I mean, this is not always the case. And you can see the right ovarian vein and the left ovarian vein over the psoas muscle. Look how dilated and big they are. You see the 2 iliac arteries and there are iliac veins or cava. Actually, there's 1 iliac vein on one side. And you see now beautifully on this view, the right ovarian vein that goes to the cava, the left ovarian vein that goes to the renal, right? And the cava below the renal level is missing. You see all these big collaterals here. Now, when having, obstruction of the cava from thrombosis or having, hyperplasia or aplasia, typically there are multiple collaterals to bypass the obstruction. And in fact, obstruction of the cava on its own, or even ligation of the cava, as we did with the clips in the past, right, is well tolerated. In most times, people end up having nothing or some, mild to moderate swelling. Here are all the different plexuses, superficial and deep that bypass the obstruction. And when you see this typical appearance with these big collaterals in the abdomen, is because the patient has caval or iliocaval obstruction. So recently, well, actually, this is in press. We just, published a paper in the European Journal of Vascular Surgery, looking at the prevalence of inferior cava anomalies and their significance in impact clinical practice. So what the paper adds in the literature, the prevalence of IVC anomalies is about 1% in the normal cohort. The types of anomalies were different between the groups. There's duplication left-sided cava and megacava, where the most common anomalies in the normal, control. Where aplasia and hypoplasia are the most common anomalies in DVT patients like we described earlier. The risk of hypoplasia or aplasia was significantly higher in deep vein thrombosis patients, especially in patients with iliofemoral DVT. Therefore, if you find young people with iliofemoral DVT, it's very important to assess, the inferior vena cava, because eventually you may have to treat these patients, and even a hypoplastic vena cava can be dilated properly, and a stent can be placed. Now going to the ovarian veins, where we know one main ovarian vein on the left that goes to the kidney, to the renal vein, and the right goes to the vena cava, right? They usually have, there are 2 to 3 veins or even more at the L4 and below. The veins have 2 to 3 valves, so the ovarian veins do have valves and direct the blood from the pelvis to the heart. And the diameter usually is 2 to 4 millimeters. And here you see a selective venogram for the left side, showing the incompetent, system, and a duplicated top to bottom ovarian vein. And here is further dilated. You see the ovarian plexus and the periguterine and transuterine plexus in here. And here is catheterization on the other side, which is a bit more difficult. And you can do it from the groin, but typically it's easier to come from the jugular vein to cannulate the ovarian vein on the side. This is a nice slide from Mr. Hobbs, where I used to assist him in the operating room in London. And you see there are not coils at the time, so if you do the mini incision, right, transfer incision here, and then we'll expose the ovarian veins, basically remove the ovarian veins, like you see. And look how complicated the system, how many veins are in this area, right, like we saw in the venogram earlier. His select characterization of the left ovarian vein from the right to the jugular is the reflux on and the vein is very dilated. You see, of course, there's veins on the side here. The reason I put this picture, I show you a few pictures of the ovarian veins. Believe it or not, I never seen one patient has exactly the same ovarian system like another. Every venogram is basically different. Talking about anatomy, I mean, in lower extremity is in the abdomen is even worse than pelvis. The asymmetry is, the norm. And here is the reflux in the ovarian veins with the transabdominal ultrasound. The flow is in the opposite direction, like in the saphenous vein. The vein is dilated with 10 millimeters. Remember, the normal diameter is 2 to 4. And here you see 3 ovarian veins. Remember earlier, right? Variations. Look, 1, 2, 3 ovarian veins. And you see here very nicely the diameters, all of them are dilated reflux. But we said the ovarian veins do have valves. Here we do the ovarian tapping technique. The valve holds and there is no backflow, right? And here is a typical periuterine veins, and you see reflux in these veins as well. Here you see on the starting position a video looking for the transperineal window with reflux in trans and periuterine veins going all the way down to the skin. This is using the new system we developed with Dr. Meissner, Dr. Kinlani, the SVP classification, the symptom varices pathophysiology classification. And you see now one of our patients having inferior gluteal reflux, right? Inferior gluteal vein reflux that goes to the sciatic nerve veins, that goes to veins in the skin in this area of the popliteal fossa, connects to the small saphenous, and independent reflux in the great saphenous vein in the below knee segment. Here you see the left ovarian vein with huge reflux. Here you see the sciatic nerve varices with reflux, right? And you see here the inside the nerve and outside the nerve. And this patient basically has no pelvic symptoms, so it's S0, but had pelvic varices, right? Had also compression of the left renal vein, and had also reflux in the left gonadal vein, left interiliac vein, and right interiliac vein. And the pathophysiology was reflux was non-thrombotic. That's basically classification for the SVP. And for the CAP, for this leg would have been 1 to 3, patient has swelling or symptomatic. The etiology was primary, had superficial perforated deep vein pathology here because of the sciatic nerve was involved, and had also reflux in the GSV and the sciatic nerve veins. So this is the SVP and the CF classification of the same patient. Here is a patient with compression of the left renal vein. You see the vena cava here. This is the severe beaking of the CAT scan. Right? This is the left kidney. And what we call the nutcracker syndrome, we try to avoid the terminology of the syndrome. This is basically left renal vein obstruction. You see here how the vein is being flattened here. And see all these collaterals. See on the ultrasound, the SMA on the top. This is the aorta. This is the IVC. This is the tapering of the vein over the aorta. This is the typical narrow aortomesideric angle. These patients are usually lean with a BMI of less than 25. Actually, in our prospective study, the BMI is usually around 20 in these patients. And you see here in the zoom view how the narrow string of the renal vein, and basically on this patient, don't see on this image, the flow is diverted in left ovarian vein. Typically, this people and they're skinny. The artery angle is less than 25. There is a pre-stenotic, post-stenotic renal vein dilatation, right, with the diameter ratio of more than 4 and the velocity of more than 4. And there's collateral development by passive obstruction, but most often the flow is diverted in left ovarian vein that develops, reflux because the valves are broken down, and the reflux extends to the pelvic plexuses. You see here another anomaly. 2% of the people have a posterior aortic vein, like here it's the spine, it's the aorta. So the renal vein goes behind the aorta. So the vein is compressed between the aorta and the spine, right? So you're having the posterior nutcracker. So anomalies are rare in the inferior vena cava, iliac, and common femoral veins, but very frequent below that level. They include duplication, triplication, hypoplasia, and aplasia. Knowledge of this variation is important to minimize the false negative findings and improve the management of patients with venous disease. Do not forget that the veins return the blood to the right atrium. The return is impeded in case of reflux, obstruction, and right heart failure. These conditions lead to venous hypertension that results in the development of the chronic venous signs and symptoms. Also, do not forget that other factors, right? So don't look at the patient as an anatomic variation. What about the patient's flat feet, hollow feet, right? What the patient a fixed ankle joint, what the patient is obese. So you have to put all these factors together to figure out what's going on with the patient. I would like to remind you, since you're trainees, it's free for trainees. You can come to our Venous Symposium in May 1023. Dr. Papas, as you see here, is one of our leading experts, has been and still is in our group here. And you can also present your own research there, meet other people, network, etc. Thank you so much for your attention.
Thank you, Nicos. As always, a very comprehensive discussion. So I'm not going to let you go without asking this question about pulsatile flow. I know you and I have had this discussion before, but I see this almost routinely, at least 2 or 3 times a week in the office, and the techs are, informing me that there's a patient that may have pulsatile flow, especially in the deep system. Is this a clinically relevant finding? Should we be doing further workups on this patient, or should we just, it's one piece of a puzzle? What are your feeling about pulsatile flow in the venous system?
Simple things first. First, do you see if the patient has any right heart failure, which is common in these patients. But the people can have pulsatile flow because they have, significant skin damage or laceration and the active inflammation, right? It can do that. Or the people might have, some, at the same time, any leg infection or any significant inflammation of the lower extremity. So if the patient does not have any significant inflammation in the lower extremity, pulsatile flow most likely will come, from, insufficiency of the heart.
So another question about the vein of the sciatic nerve. I know most of the time people are treating that with foam sclerotherapy, but doesn't the foam cause an intense inflammatory reaction? And isn't there a risk of maybe damaging the sciatic nerve with a foam injection? What's your feelings about that?
Peter, anecdotally, I've heard of 2 cases from Italy where the patient got, neuritis, but that was temporary, so it can happen. Us, actually, what we do ideally, we do phlebectomies and we inject not the sciatic nerve veins themselves, but just the tributaries, their main tributaries, right? So, this vein is extremely varicose. There's nothing else to do. There's no any ablative techniques.
Right.
So you can do, get the vein to the highest level that you can, do phlebectomies and inject. But I would inject it really high up to deliberately have the foam with the sciatic nerve veins. I will not do that.
All right, does anybody have any questions for Dr. Labropoulos before we let him go? He's very busy today, so. All right, well, listen, Nicos, thank you so much. I really appreciate you adding to our venous and lymphatic medicine lecture series. This was an awesome discussion. We've recorded it so for the fellows, you can go back and look at this. This is a wealth of knowledge and experience that's been accumulated over a 30 and 40-year career. So thank you very much. I appreciate your time, Nicos.
Thank you, Peter. Have a nice day, everybody.
All right,
and if
care,
I can help you,
have a great weekend, everyone.
You got my email. Take care. Bye-bye.
Bye-bye.